Alex, thank you very much, and thank you to the members for proposing me to speak today. I'm very grateful that you've already all come here. I hope to learn a little bit more about psoriasis and psoriatic arthritis. And believe me, there are times when I see the mortgage bill and I wish I remained a dentist. But that said, I'm very happy actually with a career in rheumatology. So these diseases, I put down the title as they are common but commonly ignored. And I think from my own clinical experience, and I guess this will be the case with some patients, both health professionals, rheumatologists, will not have had that much in the way of treatment options until quite recently, and we're still quite restricted in what we can give patients, and particularly at the severe end of the scale. Patients are often not given treatment which they should be getting, and also we need to do a lot more research to make sure the options for patients who have very severe disease are actually optimized. So when I was first asked to speak here, and I hope you can all hear me at the back, when I was asked to speak here for up to an hour, I thought back to my medical school days, because we were always told that if you talk for an hour, this is the net result. And so I will try and make everything as brief and concise as I possibly can. And I'm also quite swayed by those of you who are sort of quite adept at sayings of other people. Mark Twain saying that actually it's better to keep your mouth shut and for people to think you're an idiot than to open it and remove all doubt. So unfortunately I have to speak, so I hope that this will be a talk which opens up some interest in these quite common conditions. So what is psoriasis? A lot of you may know people who have psoriasis, may have it themselves, and basically psoriasis is a chronic disorder. In other words, by chronic we mean there is no cure for it really. This can present at really any age. Most commonly presents in early adolescence and early adulthood, but you can get children as young as 2-3 years old who develop very early psoriasis. And in the USA and Europe, it affects quite a large number of people. So we're talking roughly about 25 million people throughout the USA and Europe. So this is not a rare condition. And yet, not many people know about either psoriasis or psoriatic arthritis. In the UK, again, as I've said, it's common. And if we say 2 to 3%, that may not sound like very many people, but diabetes affects 3 to 4% of patients, and everyone knows about diabetes. And diabetes has health impacts, economic impacts, as well as physical impacts on patients, but so does psoriasis, and it's nearly as common. So there are good studies that show there's a reduced quality of life, that patients with psoriasis actually don't have the same levels of employment. They have much lower income. Employment, for example, can be reduced by up to 50% compared to patients who don't have psoriasis. Now, add to that sort of burden, a personal burden, if you like, for patients, is the fact that they don't contribute to the economy of the country as we would like, even though they want to. And added to that is that therapy itself will cost huge sums of money, and as we enter an era where drugs, medications, new ones come out really quite regularly for chronic conditions, we realise that actually this may lead to a real problem further down the line, because many of these drugs are very, very expensive. Now, when I was looking for celebrities who have psoriasis, I looked at people who I would remember. So Joseph Stalin's got psoriasis. Shame the heart disease didn't kill him earlier, but there you go. We've got other people like Dennis Potter, a lot of you will know, who wrote The Singing Detective, and based around his experiences of psoriasis. But my daughter was quite keen on these people, who I haven't got a clue who they are until I looked them up. Far too young for me. But you can see all these three people. This is Eli Roth, who's a film director and wrote or directed a film called Cabin Fever quite recently. and that's about a flesh-eating bug. And it was inspired by the fact that he had very severe psoriasis on his legs and akin to a flesh-eating bug. So he used that experience to direct that film. Kim Kardashian, who, please don't ask me, I think she's one of these celebrities that is just a celebrity, but she has psoriasis. And Ellie English, who is a well-known model in the USA, has psoriasis. Now, you can see on the face of it, you know, what's the big deal? These are successful people. So why am I talking to you about something that, you know, could be hidden quite well? Well, it's not that well hidden. And this is the same model, Miss English, who won America's Top Model, I think, in 2006. And you can see she actually recently had a major flare-up of her psoriasis and didn't hide it. Thought, why hide it? Because we can try and help other patients with the same condition. And this was in between therapy. So you can see, on the face of it, people may look very handsome, very attractive. Underneath it, and not only in the skin, but psychologically, there are real challenges ahead for psoriasis and psoriatic arthritis. What do patients say? I mean, if you were to see someone with psoriasis or with the arthritis component of the psoriasis, what would you say? Well, patients often feel that patients with psoriasis are less attractive, understandably. They wouldn't want to be served food in a restaurant if they had somebody who had psoriasis. A lot of people think it's contagious, and I've had one patient who I saw just a few weeks ago who told me he went into a swimming pool and was asked to leave, not by the public, but by the staff members, because he had psoriasis, and they thought, this is going to be contagious, you have to leave. And many people think it's caused by poor hygiene. So you can see there are real challenges for patients who have psoriasis to try and overcome so many hurdles that are put before them, not just by the condition, but also by the attitude of many other people. So this is the sort of thing we're talking about. And in many ways, you can understand why the general public might feel that this is the sort of person that they wouldn't want around them. This is a very severe case, clearly. There are different forms of psoriasis as well, and the most common one is what's called plaque psoriasis, where you have these fairly well demarcated areas which are quite often raised, can be itchy, can be painful, which are scattered around the body. This is by far and away the most common source or common type of psoriasis. Otherwise, less common are forms of psoriasis related to infection. This one's called guttate psoriasis. Guttate just means drop in Latin, so it's called guttate psoriasis, and often is linked to infection, particularly streptococcal infection of the sore throat or chest infections. Otherwise, another type, less common, again, is palmoplantar pustulosis. So these are pustules with fluid in them, and again, you can see this is a fairly aggressive condition and quite often linked to joint problems and quite often linked to, again, to infection. And perhaps the worst form, which is erythrodermic psoriasis, which can affect the whole body and can be extremely uncomfortable, extremely painful, and very difficult to treat. Now, my particular interest is psoriatic arthritis. So clearly the vast majority of patients who have psoriatic arthritis have psoriasis as well, but it's not always the case. And patients can have, for example, a family history of psoriasis and have no psoriasis themselves, and they have psoriatic arthritis. And we gauge that by the pattern of joint problems that they have. But again, this is pretty common. And I guess my own view is that people will have heard of rheumatoid arthritis. A lot of people will have heard of rheumatoid arthritis as a debilitating condition. And about 0.5% of the UK population have a rheumatoid arthritis. So we're talking about 400, 500,000 people. And in my view, that is akin to rheumatoid. And yet, most rheumatologists, most GPs, most health practitioners won't have even heard of the condition. They won't know what psoriatic arthritis is, but they'll know rheumatoid because There's been a lot of research on rheumatoid, less so on psoriatic arthritis. But this is very common. And it's quite different to rheumatoid, and in many ways the distinction is important because as rheumatologists years ago, and still, many people think we treat the diseases the same way. But actually they are very distinct diseases. The sex incidence is equal, and in rheumatoid women tend to get affected far more than men, but not in psoriatic arthritis. And the pattern of disease is actually very different as well. So in rheumatoid arthritis, quite often the joints are the prime focus for what is happening with the condition. So we can often assess the disease activity by looking at the joints specifically. In psoriatic arthritis, that's just not the case, and you will often find patients who have problems with their tendons, such as the shoulder, the golfer's elbow, or the tennis elbow areas, which are inflamed, and people dismiss this as just sort of repetitive strain. But actually it's part of psoriatic arthritis. With rheumatoid, we just look at the joints primarily. With psoriatic arthritis, very different, and therefore much more difficult to actually say how active the disease is or not. There's often quite a long lag, and this again makes the diagnosis a little bit more difficult because patients can have psoriasis, and most patients develop their psoriasis well ahead of psoriatic arthritis, usually about 9 to 10 years of psoriasis before they develop joint pains. Sometimes in about 10% of patients they get psoriasis and psoriatic arthritis together at the same time. And some patients, as I've mentioned, will have the psoriatic arthritis ahead of their development of psoriasis. And as I say, the joints, all the tendons, both seem to be focus of problems with psoriatic arthritis. We think probably the tendons might be the real key as to why this condition occurs, but we don't yet know. So this is what psoriatic arthritis looks like, and you can see the classical chronic plaque psoriasis in this patient, and swollen joints here, and deformities here. So if I put my finger straight like this, I can't bend it the wrong way. But these fingers can bend the wrong way because the tendons that stabilize the joint are disrupted. And you can see there are obvious swellings here as well. And one can visualize from that really, this is not going to be easy to manage on a day-to-day basis for the patient. They're not going to be able to do simple things like picking up cups of tea, turning door handles, putting the key in a lock. Simple things are going to be difficult. This is another patient with again, joint swellings around this array of joints. And you can see another characteristic feature, the nail problems that often disfigure patients, because the nails often come off, and you can see a nail coming off here. They're often pitted, and they can be very abnormal looking. So they don't look nice and shiny, they look mottled and abnormal. There are many other features with psoriasis as well, and it is really considered very much a multi-system disorder now. So whereas 10 years ago we would think of psoriasis basically as a skin disorder, perhaps with some patients getting joint problems, now we know that actually it is part of a spectrum of disease which affects the eyes, which can affect the bowel, and can affect the tendons, as I've said. There are nail changes, and we'll come on to this facet, the heart disease and strokes at a later stage. This is the kind of general picture of patients that we often see. This gentleman is overweight. Now, you might say, well, most of the population's overweight, but actually they're not overweight because they eat too much and they don't do anything. They're overweight because of their disease. And they're overweight of their disease because there are alterations in metabolism, there are alterations in their psychology that lead them to having this kind of body shape. There's a higher instance of alcohol abuse with psoriasis, and a significantly higher proportion than you would find in the general population. They tend to be overweight, as I've said. They tend to have fatty livers. And we quite commonly find patients who may be slim, who may be overweight. It makes no difference. Uniformly, they all have a lot of fat deposit in their liver, and that's akin to diabetes. That's the same sort of process that happens in diabetes. They often have high lipids, and we'll come to that a little bit later on because there is a little bit of a paradox, as I said, about lipids. And they can have high blood pressure. And these are all key features, obviously, in conditions such as heart disease. So we build up a picture now, really, not just of the skin and joints, but the bowels, the nails, the tendons, the eyes. The psychology of psoriasis is becoming better established, and the heart disease issue, which we'll come to at the end. So not just the skin and not just the joints. So what causes this kind of problem, which is so diffusely spread through the body? We mentioned sort of family history being particularly important earlier on in patients, particularly who have joint problems, who may not have psoriasis. First thing you ask is, do you have psoriasis, if they fit the pattern for psoriatic arthritis? Second question is, does anybody in your family have psoriasis? And it's quite extraordinary that really a lot of patients will answer yes. And there is a heritability. Even with patients without psoriasis, patients who have frozen shoulders or tendon problems, we think of those as isolated problems. And I see a lot of patients who've pulled a muscle in the shoulder, who've got a tendinitis around the elbow, and you think, well, it's a one-off. You've done something to upset the tendon. But actually, if you look hard enough, there is a heritability even to those one-off problems. And these tendon problems can be inherited. And if you look quite closely, frozen shoulder, tennis elbow, there's actually a heritability of about 40% in these. In other words, if you've got frozen shoulder, which you might think is a one-off, then actually the likelihood that your sister or identical twin or whatever will have a similar problem is very high. And it's the same with rotator cuff tendinitis in the shoulder. And these are problems we often see in psoriasis. Looking further at genetic studies, people have looked at the Achilles tendon, which is a fairly common site to get tendon problems in psoriasis. And there is a molecule called growth differentiation factor 5, or GDF5, which seems to be quite key and is an inherited disorder of Achilles tendon manufacture. So there may be not only a genetic link to these tendon problems, but they might be explainable by molecular defects. Not uncommonly, as I've said, we find patients with psoriasis have a strong family history, and this is a fairly typical family history. So we often find patients don't just have psoriasis, but for example, Crohn's disease in this case, which is a bowel disorder. And psoriasis and Crohn's disease can be found in the index case, they can be found in siblings, they can be found in several members of the family who actually have followed on from one of the index cases. For example, this being the Father, Son, I won't say the Holy Ghost, but daughters and offspring. So this is not at all an uncommon phenomenon. It may be diabetes, and we often see diabetes, for example, being inherited with psoriasis, so to speak. There is also a good feeling that actually psoriatic arthritis behaves in very much the same way. So if you've got a first-degree relative, in other words, your mother or father, or your siblings, with psoriatic arthritis, what's the chance of you getting psoriatic arthritis? Well, the chance is actually pretty strong. You will develop psoriatic arthritis. It's a very strong risk. So 30 just means that compared to a control population who don't have psoriatic arthritis, your relative risk compared to that group of developing psoriatic arthritis, if one of your relatives has it, is 30 times. Similarly, psoriasis, again, we've mentioned that there's a familial aggregation, and indeed, that's what we find. The relative risk for rheumatoid arthritis is a little bit lower, so clearly these aren't identical conditions. Looking deeper, I'm always amused that we've got all this genetic data now, and we've managed to map the human genome in great detail. We know where all genes are. We don't know what they all do, but we know where they are. So we've developed techniques called genome-wide association studies, which have tried to look at certain diseases and see whether actually certain genes might be linked with certain diseases. The amusing thing is, I think it just has confused everybody even more. And the reason for that is, it's simply not the case that one gene with many of these chronic conditions causes one disease. So we can't isolate one gene, which is the key or the lock, if you like, to unlock the rest of the series of diseases. But there are clusters of genes which seem to be associated, and without going into too much detail, certain immune cytokines or protein mediators can be associated with psoriasis, can be associated with psoriatic arthritis. And this might be one of the explanations for why the familial aggregation of these conditions seems to be so strong. People have also looked to see, well, if you've got one inflammatory disease, it's generally the case that you might get another. And the reason for that is there might be some genes that actually link together other inflammatory conditions. So this gene, or gene cluster, or group of genes if you like, makes it more likely you'll get not only psoriatic arthritis but rheumatoid arthritis. And we see this association really throughout several of these gene clusters. It's quite an interesting area, but as I say, the jury is really out on whether we can identify one particular gene that causes many of these conditions, including psoriasis and psoriatic arthritis. And it's more likely that we're going to see in the future that a combination of environmental triggers, which may be infective, maybe viral, maybe nutritional, might be actually causing these genes to malfunction and cause disease, rather than the genes themselves being the primary problem. What do we actually see microscopically in psoriasis? Can that help explain why the condition happens? We've already seen that genes might be one of the possible factors involved. And I'm sorry this is overcomplicated, but essentially what you see is thickened skin, as you would expect to see. But not only that, you see a lot of collection or aggregates of what are called lymphocytes, which are immune cells, which are quite key to many, many diseases. These immune cells seem to have gone a little bit mad. Now, we don't know why they've gone mad, and we don't know what the trigger is for them going a little bit potty. But there certainly seems to be a trigger, and certain cells within the skin here may take up these triggers. There may be a virus, for example. These cells then release other proteins, which then attract other cells and cause the changes that one sees in the skin. We're not clear what comes first and what is the trigger. So there's clearly a lot of work to be done around this area. So you may be asking, well, that's the skin, but is there any way, why should the joints be affected? What's the link? And the answer is we don't know. We don't know why 30 to 40% of patients with psoriasis get psoriatic arthritis. And if you look at biopsy specimens of joints, you don't see the same changes as you do in psoriasis, oddly enough. This is a distinct mechanism. It's not the same disease. The cells are different, and the protein mediators are different. So we don't know why some people with psoriasis will get psoriatic arthritis, some won't, because the disease process does not seem to mirror the skin, and it seems to be a slightly distinct process. So there may be other things that are causing patients to have arthritis. So I'm going to stick to psoriatic arthritis specifically for diagnosis rather than psoriasis, and I'll leave that to the dermatologist if that's feasible. But by and large, what we do is we examine clinically, and there is no blood test marker for psoriatic arthritis. So we have to use our clinical judgment as to how to diagnose this. And that's part of the reason why it's probably very underdiagnosed. It can be difficult. So you see here, One of the presentations may be just a very swollen knee joint. And this is a patient who has what's called a monoarthritis. There may be a history of psoriasis or a family history of psoriasis. This can be very debilitating, and it can be very, very difficult to treat. Further down the line, we have patients who have a polyarthritis. In other words, as we've seen before, many joints are affected. Moving on, we may have patients who don't have any of these features, but just have swelling in the joints, or in the tendons rather. And this is the Achilles tendon, and you can see this is very enlarged, particularly low down where the Achilles tendon inserts into the bone. So this is Achilles tendinitis in a patient with psoriasis. You can have swelling of the toes. I don't know if anybody wants to hazard a guess as to what we call these. Any ideas? Because they look like sausages, so we call them sausage toes. Wouldn't want to eat one, though, on a Saturday morning, but sausage toes are what they're called, and they seem to reflect, again, very strong tendon involvement rather than joint. And this is probably the worst case, and this is called arthritis mutilans. And this is severe arthritis, and we'll see one or two pictures of the x-rays of these kind of patients in a second. This is more common, the joint here with the nail changes that I've said. And the nail changes often are a bit of a giveaway to the diagnosis. And you can see this particular joint and the nail are in close proximity. And there is some evidence that actually if somebody gets nail changes with psoriasis, they're much more likely to develop psoriatic arthritis, particularly in these joints here. Clinical acumen is all very well. There are some patients who don't have any of those obvious swellings, and so we have to look a little bit harder. And we can see that some patients will need x-rays, and that often guides us as to what the diagnosis might be. And you can see on this patient here, I've sort of highlighted what would be really a normal joint here. So nice and smooth, no damage, and an abnormal one, which you can see actually is completely disorganized. There is no smoothness to the joint. It's what is called a pencil in cup appearance. So it's really very much like a pencil's been shoved into a cup. And that's what it's called. That's the radiographic name for this appearance. So this is severe psoriatic arthritis. This is a patient who had arthritis mutilans. And this is called mutilans simply because it is so mutilating. It is extremely aggressive. And you can see here, there should be two bones here, and they've disappeared, really. Here they are, okay? This should be a straight array of bones. You can see on the other foot, again, the straight array has been disordered, and there's been a lot of movement of the bones away from the center. And here, really, you'll be hard pushed to say that's a bone of any kind. All the joint has dissolved away, basically to nothing. And in the hand joints, the similar sort of pictures here. Again, if you look here, this should be a nice straight array of bones and joints with a nice smooth rounded joint. There is no joint here. It's completely gone. And this is the kind of picture that you will see in this particular patient who's had psoriatic arthritis for about 50 years. And what we see with these patients, if this patient had rheumatoid arthritis, for example, they would probably by now have burnt out. And we often see that with rheumatoid. The disease tends to burn out the older you get. It doesn't always, but by and large, that's, as a rule of thumb, that's what happens. Now with psoriatic arthritis, that doesn't happen. So I've got about 4 or 5 of these patients. So there's not a huge number, but it's a pretty nasty, aggressive disease, who have had this condition for 45, 50 years, and you'd think, well, this is all burnt out, I can't do anything. But there are ways of finding out, actually, has this burnt out or not? And my own feeling is this never burns out. This is ongoing, so this goes on in at a low-grade level, but very, very persistently for decades and decades, and does not burn out. And one of the ways that we actually diagnose whether disease is active or not is not just clinically, But we also look at newer instruments, particularly ultrasound. And ultrasound is a very useful tool for looking at joints, not just for pregnant ladies, it's very good for that as well, but for joints it's excellent because what it shows is in the right hands, obviously myself being a layman and with ultrasound would not be able to tell one bright part from another. But what you're seeing here is a joint, and you can see the two ends of the joint. And what the radiologists can tell, if they use special techniques, and this one is called power Doppler ultrasound, is that you can see the joint here, but if you switch the power Doppler ultrasound on, what you can see is this. And this is blood. So why is that important? Well, that shouldn't be there. And what it tells you is that the joint capsule has got a lot of blood going through it. And that means it must be inflamed. That blood is from new vessels that have arrived there because the joint is severely inflamed and new blood vessels sprout into the joint and cause this enhanced blood flow. So you can see from that a static ultrasound is fine. It'll give you a little bit of information, but the power Doppler ultrasound actually tells you something important, that this disease is active now. Not active in the past, as X-rays show, but active now. And that means this patient needs treatment, simply put. So it's a very useful tool, and we often use this in cases particularly which is very, very difficult to say whether they're active or not. And those patients with arthritis mutilans, we find that actually activity is ongoing. It hasn't stopped. There is another paradox here, and this study was quite an impressive study of patients with psoriasis who don't have any joint problems of any kind at all. And this group did an ultrasound study, not really looking for any activity, but just looking at the Achilles tendon here. And what they found remarkably in patients who have just psoriasis with no joint pains is that patients with psoriasis often have Achilles tendons which are markedly thickened. I'm sorry if this doesn't project that well, but the width of this Achilles tendon, which is normal, is less than half of this Achilles tendon, which is abnormal in a patient with psoriasis. Not only that, they often develop bony changes, and these sort of sharp areas here, which is called an enthesophyte, or basically just a sharp spicule of bone. So these are asymptomatic patients. So again, it just suggests that what we're seeing is quite paradoxical in many ways. So you can have psoriatic arthritis, technically to all intents and purposes, in patients who don't have any symptoms whatsoever. But what we do know is that this damage may eventually actually lead to pain and restriction, and so needs to be picked up quite early. And by all means, sorry, I didn't say this at the start, but if anybody has questions, please feel free to stop me in the middle of what I'm saying. MRI scanning is another way that we can look at the joints, and osteoarthritis, which often affects these kind of joints near the nail, and psoriatic arthritis, to all intents and purposes, might be quite similar. But actually looking at high resolution MRI, we can see that actually, again, the tendons here are actually seem to be the focus of the damage in psoriatic arthritis. So this is psoriatic arthritis. You can see the nail bed is markedly thickened compared to degenerative osteoarthritis, which a lot of people's relatives, grandmothers, etc. would have had in days gone by. The process is not identical, even though the same joint is affected. And again, it seems to be largely the tendon here rather than the joint which seems to be affected. So another useful tool for looking at the joints. So what works? So we've got patients who have debilitating joint problems and may have very nasty disease. Now ideally, what we would like is a therapy that works for both, sort of a buy one, get one free, if you like. And some of these therapies do work for both. But it's remarkable actually, because in the last 10 or 15 years, we've had an explosion of interest in rheumatoid arthritis, which has largely driven a lot of the drugs that we now use even for psoriatic arthritis. But the evidence for them is so poor that actually you wonder why you're prescribing these drugs at all for the joints. So methotrexate rheumatologists will use this up and down the country, myself included, for the joints. Does it work on psoriatic arthritis? Who knows? We don't have enough evidence. Sulfasalazine likewise. Leflunomide is a slightly newer drug, and there's some evidence it works for the joints. So we're really stuck in an era of some of these older drugs where we're not actually sure whether they actually work at all. But we use them because we don't want the patient to go away thinking we're not doing anything. It's not a really particularly good way to treat patients, but unfortunately that's the way we have to go sometimes. Newer therapies, however, and these are the expensive therapies I was talking about, are coming slowly on stream, and they have, to a large extent, revolutionised a lot of our treatment of many chronic conditions. The most common biologic agents, and they're called biologic simply because we have a mechanism by which they work on certain, by using certain antibodies. The most common of these is anti-TNF alpha. So if you were to treat somebody with anti-TNF alpha, I just want somebody to hazard a guess as to how much do you think this costs per patient per year? Anybody want to start the bidding? £3,000? 2,000 to 3,000 per patient per year. Anybody want to go higher?
I think more than this.
How much would you think?
Or
So we're saying what, about 7,000, 8,000?
more than 20,000.
So, okay. So, yes, sorry. 15,000? Okay. So not quite, but not far off. I mean, we're talking about 10 or 11,000 pounds per patient per year. Now, if you multiply that by 500,000 psoriatic patients, 1.5 million psoriasis patients, that's just psoriasis and psoriatic arthritis. And you can see why these drugs are now rationed, okay? And there's no two ways to say this. These drugs are rationed. And they're rationed because they cost so much, but they can be very effective. And by rationing, what I mean is patients often have to try the drugs that we've said before may not work particularly well. They have to try those before they can be considered for any of these drugs, and despite that, they have to have aggressive disease. And this is an expensive business, and it won't get any cheaper because more and more drugs will come out in the future which will be just as expensive. There's a newer drug, ustekinumab, or Stelara as the trade name, just as expensive. So you can imagine, people in government sort of losing their hair over this quite easily, wondering what on earth are we going to do? How do we actually restrict the number of patients that can get this drug? Because really, without that restriction, unfortunately, the health service will go bust. Isn't it already? Sorry.
Sorry, could you explain what the biologic agents were?
Yeah, these are the biologics. So these are the biologic drugs. Sorry.
Excuse me, but which
Yeah.
would you say out of all this
Yeah.
is the best one?
Well, there is no best one. No, there is no best one. So I think that's really important. What we don't do is give treatment to patients based on the best drug at the moment. Okay, we tailor it to the patient. So, for example, infliximab, you have to come into hospital to have that. Okay, so if you come into hospital, you have a drip, and the infliximab is given, and it's given every 3 months or so.
Are there any side effects to that?
The side effects with every drug. There's not a drug known to man that doesn't have a side effect. So there are side effects. Infection risk is one of them, particularly tuberculosis. Okay, etanercept and adalimumab are other drugs which are given by injection, but the patient can give them at home. So it's much more convenient for patients to have these drugs at home rather than coming into hospital, which is always very expensive. Coming into hospital, having a nurse there, these are expensive options. And that means infliximab tends to be a more expensive drug simply because patients have to come into hospital, we have to employ a day case nurse, there has to be a room, there has to be all sorts of other people around to give this drug. So we tend not to give infliximab unless patients actually can't infuse it or are too scared, and some patients are too scared to self-inject. Okay?
Why do they have such mystifying names? Is that deliberate? Is there a
There is no rationale for the names, and I think there is a process for approving names, which I'm not privy to, but I know what you mean. And these names are the generic names for the drug. The trade names, so etanercept is Enbrel, and adalimumab is Humira. So it's a little bit easier. So the trade names are what the companies like to call their drugs. So they try obviously to make it a little bit simple, but the drug naming authorities, and there is one, often give them very, very sort of odd names. Not guilty is all I can say. Yes.
People have something like Crohn's disease or something, take these agents, and would that help?
No.
Is it people with
There are some patients with Crohn's disease who are eligible for these drugs, not all.
I mean, that's a cost.
No, absolutely. I mean, if you have both diseases, it seems sensible to treat with a condition that can affect both. But there are certain rules that you have to obey before the patient can get the drug. So, for example, with psoriatic arthritis, you need to have 3 swollen joints and 3 tender joints. And the patient's functional status, in other words, what they can do on a daily basis, has to be low enough. So those criteria have to be filled. So it's not just a question of you've tried this drug and you've tried this drug, you've got 1 swollen joint, 1 tender joint, you can have the anti-TNF biologics. Unfortunately, the issue is you still need to be severe enough for us to say that you can have them. Sorry, yeah.
Why are some medicines, some drugs more expensive than others? I mean, apart from the ones where you have to go to the hospital and have that.
Well, I think a large part of that is what drug companies, obviously, they do a lot of research. And I think there's a lot of negative publicity about drug companies, understandably, because their aim, and I see a lot of drug reps who try and say, why didn't you prescribe this, that and the other? Their aim, and the first thing I say to myself is, they want to make money. End of story. Okay? Of course they want to do it safely, okay? But that's their objective. And so, inevitably, they will plough a large sum of money into the research. And I think it's important that whilst I've said they want to earn money, actually they're doing a lot of hard work to get these drugs out. And I think that's to be commended. But the bottom line is they want to make money, they plough a large amount of money into research, and they have to recoup that before the patent runs out. That's why they're expensive.
Hello. How many years would it take for the drug companies to recoup the research money into a drug before it drops down and becomes generally affordable?
I think that's very variable. I think for these drugs, these haven't yet sort of all come off patent. And I think it can be sort of 10, 20 years sometimes with some drugs before they come off patent. So I don't think it's a short period of time.
It just seems, I mean, I can understand that when they're first launched, they're extremely expensive because I understand the amount of research and manpower and brain power that's gone into developing them. But it seems disproportionate that they don't recoup their loss in a shorter time when they are when they're so useful that they're generally prescribed.
Well, I agree with you, and I think that is more an economic kind of case for the drug companies to answer. Be that as it may, there are some drugs which actually, some of the newer drugs, so there's one called golimumab, which is similar to these drugs, a newer drug, which the drug company actually says, will pay for the first 3 or 4 months of treatment. So they've now, I think the drug companies have got the message, actually these are really expensive. Okay, so they're now stepping in because governments are saying, actually, we're not going to pay for this. We're not going to approve it until something is done about the pricing. If this were £2.50, everyone would be on them. They're not. So clearly there's an economic case that drug companies have to make money. That's the way we get new drugs, and that's fair enough. But I'd agree with you that maybe the patent period might be too long for some of these drugs. But I think that's an economic issue, that the drug companies obviously have sort of committees discussing these kind of things. How long should we patent this for? And and all the rest of it. So I think it will be a long time before these come down in price significantly. But there are other ways around it, and perhaps a bit of innovation like drug companies footing the bill for the first few months or the first year might be one of those options.
What about creams? If people take some of these drugs and the side effects, they're going to land up in hospital with the side effects after taking what they're taking there.
Well, we do get...
Discussions of what they're taking.
Well, inevitably, and as I've said, when I was a medical student, I looked through, there's a guide to all the medications we have called the BNF, and there's not a single drug in there that doesn't have a side effect, okay? So an aspirin will have a side effect. It can make you bleed, and there are 2,500 patients a year that die from bleeding due to anti-inflammatories or aspirin-related problems. So anything and everything has a side effect. So inevitably, sorry?
Simpler way, like certain creams, like Metrazone or things like that.
Well, there are some creams that are used for the milder psoriasis. We're certainly not saying all patients need these drugs. They don't. And there's a large cohort of patients that don't need these drugs. Okay? So we're not saying that absolutely everybody needs this. So there'll be a large number of patients who have very mild psoriasis. Most of my patients with psoriatic arthritis need more potent medication, and that's just a fact of life, and that's simply because a lot of patients actually worry more about their joints because it impacts on what they can do on a daily basis than their skin. Both are important, but the skin can be hidden, for example, okay? The joints can't be because you're working with your hands all the time. So inevitably, a lot of patients will need these drugs, but it's by no means all of them. But the scale of the number of people that actually do need them, considering that psoriasis, psoriatic arthritis are just 2 diseases, and we've got 40, 50, 60 diseases that we often treat that might need these drugs, the scale of the problem is quite immense.
Is there any place for physiotherapy with treating these conditions?
Yeah, physiotherapy. I've kept it quite simple because I didn't want to get bogged down in the sort of the minutiae of the treatment of these conditions. But physiotherapy undoubtedly does help certain patients. We're quite active in using physio because it strengthens the muscles, it reduces pain, and psychologically it makes people feel better. So there is a role, but that doesn't stop the disease. There's no evidence that physiotherapy actually stops the disease. So you will still get progression, and that's the problem. If it progresses, all the physio in the world is not going to help you when you've got arthritis mutilans, and it's progressed that far, as some patients do. By and large it is, yeah. And for psoriatic arthritis. For psoriatic arthritis. Sorry.
Is it progressive?
Yes, is it progressive? So by and large, the majority of patients who have psoriatic arthritis will slowly progress. Okay? Over a period of 9 or 10 years, the majority will progress, not everybody. Okay? Now, part of the reason for that is, we don't leave a natural history of psoriasis or psoriatic arthritis anymore. We treat patients. So there's no good data because 50, 60 years ago would probably have been the time to look at this when there were no effective therapies. Now we think some drugs might work. They may not, but we need more evidence. But if we treat them, actually some patients will stop progressing and will actually stabilise. Some patients will get better. But the majority, if you left them without treatment, yes, they would inevitably progress. And there is some evidence for that.
Does that apply to psoriasis as well? Is that untreated?
Untreated psoriasis, will it progress? Well, it's probably a variable course. By progression, if you mean will more and more of the body become covered in psoriasis, the answer is no, because it's a kind of a waxing and waning disease. But inevitably, you'll get times when it flares up, and it covers most of the body, and other times where it actually gets better and covers a much smaller proportion. So it's not progressive in that sense, that actually it progresses to cover all the body. The arthritis probably is, though.
What about alternative medicines? I mean, for some reason, I think the natural hot water, there is a source of natural.
Yeah, well, it's in...
It can be helpful for joints
there's no evidence that actually that helps the joints, okay? But on an individual patient basis, rather, a lot of my patients will, for example, go to the Dead Sea, and they swear by it. Okay, so I encourage patients to go to the Dead Sea and float on the water. I think one of I think it's Art Garfunkel, who's the singer with Simon and Garfunkel years ago. He visits the Dead Sea regularly and finds it really helps the skin, particularly the joints less so, but it can help the joints. So there are those kinds of remedies which have no real evidence behind them. In other words, they haven't been subject to scientific kind of rigour. But on an individual basis, some people do find they're helpful. Yeah, absolutely. What I might just do is continue the talk, and we can, by all means, if we stop at the end, we can then go through some more questions. But I don't want you to be here till midnight, so I'll try and finish. We've already mentioned the biologics, and clinically they seem to work well, not in everybody, but probably about 60–70% of patients they seem to work very well in, both for psoriasis and the arthritis. And this is what you see microscopically. And if you give patients drugs, in this case the drugs we were talking about, the biologics, the staining represents the actual protein that is causing the inflammation, and you can see in those patients who have been treated that red staining disappears. So it does seem to do what it actually says on the tin, and you can see the skin is much thinner in this biopsy sample as well. Clinically, this is what you often see. So you can see this patient with psoriasis was treated with, I think this was infliximab this patient was treated with, and really by week 20 the psoriasis has completely disappeared. Similarly, giving other drugs, Humira, probably the easier name than adalimumab. This is a drug that can be injected at home. Severe psoriasis, the progression on this is very, very good. The Humira has worked very well, and again by sort of 3–4 months down the line the patient's much, much better. This is another patient with infliximab, and you can see the before and after pictures, and again there's been marked improvement. With the joints, some people find that actually after the first dose it's like a miracle cure, so it can be that dramatic. Infliximab again, severe psoriasis getting significantly better. So all good. The cost, as I say, is the key thing. And you tend not to find this kind of dramatic response with the older, more conventional drugs, which are as cheap, cheap as chips, really. They tend to get better, but I rarely find that patients get this dramatically better this quickly. The newer drug, ustekinumab or Stelara, again, this is an alternative. It works in a different way to the other biologics that we've mentioned, the anti-TNF drugs, and again can be very effective. And there's some evidence that it helps the joints, although in our experience actually the joints aren't particularly well improved with ustekinumab. I've had 1 or 2 successes in the joints. The majority of patients don't seem to respond. The joints don't seem to respond. And again, whilst the skin responds very well, it just suggests that the joints are affected by a very different mechanism to the skin. So this is a question for the audience, really. So a 36-year-old man who had severe psoriasis and psoriatic arthritis, and he had this biologic therapy. So how did he respond? Anyone want to hazard a guess? This is before. That's a good point. I'll put that on the slide afterwards, actually, yes. This is before.
Might be good progress.
Good progress, got better. So, I mean, that would be what we would be expecting, obviously, for our £10,000 a year. We'd expect him to get better, but this is what actually happened. And what happened is that his psoriasis went bananas. And so he went from this, a fairly well-controlled psoriasis, to this. So this is, I'm afraid, doctor-induced psoriasis. But it's induced by the drug, obviously. And this sort of illustrates, I guess, another paradox of psoriatic arthritis. Similarly, this case, This was a 36-year-old gentleman who had tried 1 or 2 biologic drugs. So etanercept, we've said, was one of the anti-TNF biologics, and he was entered into a trial of a newer drug called efilizumab, which is another antibody drug targeting certain aspects of the immune system to see if the psoriasis and the arthritis would get better. So again, you'd expect this chap to hopefully get better. This was a trial drug, so we're never very sure whether anything good will happen, but we'd had already good reports about this drug, certainly for the psoriasis and the arthritis. But again, he flared up in a big, big way. And then he also developed joint pains, which he'd not really had before. And this is not this patient, this is a sister article actually, which was written by another group describing exactly what we saw. And basically, the joint very, very swollen. This is a bone scan, which I'm afraid hasn't really come out very well, but this is what's called a hot spot on a bone scan. A bone scan is just a radioactive dye which is injected, goes into joints which are very inflamed and very, very hot and swollen. And this drug induced psoriatic arthritis. And therefore we have another paradox here. So the treatment can actually cause the disease. How bizarre is that? And yeah, we had to take him off the drug and treat him with more conventional agents. And you know, he did get better. We don't know why in some of these patients these biologic drugs actually cause the disease. There is obviously some mechanism which in certain genetically primed individuals will cause the treatment to actually make the disease far worse. And unfortunately other potential treatments, particularly for the joints, there's one called Roactemra, which is used quite widely in rheumatoid arthritis, another one called rituximab, which have also been associated with a marked worsening of psoriasis. So it again just limits the sorts of treatments that we can use compared to other conditions such as rheumatoid. So here's another case history. So a 49-year-old male who developed psoriasis in 2001. I think he'd also had a family history with his father of psoriasis, but hadn't really had much in the way of any other medical problems, had no history of using medications for anything. But he developed prominent worsening of his psoriasis all of a sudden out of the blue. And then started to develop joint pains. We examined him and he was very tender. He had some swollen joints, back pain, all new onset. And at that time, I think he was roughly about in his mid-30s or so. So not the sort of things you would expect from somebody who's maybe 75, 80, getting osteoarthritic or degenerative joint pains. A young chap in his prime, developing much worse psoriasis and developing new onset joint pains with extensive psoriasis. And I know Margaret Johnson gave you a lecture on HIV, this is one of the other issues that we get with these patients. So this is his X-ray, which shows damage here, and you can see this is not a normal joint. Compare it to this joint, which is reasonably normal. This is completely obliterated. And we did a sexually transmitted disease screen, and this gentleman was HIV positive. And we do see this quite a lot, that actually infectious diseases of various types, particularly HIV, can actually make psoriasis a lot worse. And this chap had psoriasis really as his first manifestation of HIV infection. We think there are two groups here: patients who have psoriasis, which gets suddenly worse, and patients who've never had psoriasis, which then starts de novo. And both of those can be associated with HIV infection. And for this reason, as a routine screen, and for any patients here, you'll be one of the symptoms that some patients have. So it is important to have a screening test for psoriasis and psoriatic arthritis with HIV. So this illustrates, again, as we were saying, another paradox of psoriasis. HIV, mechanistically, on a sort of microscopic level, essentially untreated HIV causes a drop in immunity. And it's certain cells called CD4 cells which fall away in infected individuals. And it tends to worsen psoriasis and psoriatic arthritis, as we've said. Paradoxically, some drugs, there's one called Elaficept, do exactly the same thing. And they deplete these immune cells, but actually cause an improvement in psoriasis. So again, another paradox which we haven't yet resolved, and hopefully in the next few years we'll have a better idea of what is actually happening on a microscopic level with psoriasis to cause these problems. Our aim is obviously to try and get the patient better as quickly as possible, and of course when we see 20-25 patients in a clinic, it is impossible to get to the bottom of all these facets of patient care and the patient's quality of life. And that's why it's so important, I think, that psychology is sort of introduced into as many facets of our care as possible. And Alex here, I mean, this is her take really on the patients that she sees with psoriasis. And there are emotional changes with psoriasis, which are quite distinct to other skin conditions. And I think Sandy McBride and Alex have looked at eczema, for example, and the sort of psyche that psoriasis patients have is actually quite different to other patients with other skin conditions like eczema. And as you can see, it's all fairly negative. You know, it's not as if people are running out there saying, look, I've got psoriasis, isn't life wonderful? It's not like that, it's quite the opposite. So you can understand why the levels of unemployment, the levels of social interaction, if you like, might be slightly different and might be subtly altered. One of the ways that this can be measured, and psychology has a lot of outcome measures, not many of which I understand personally, I'm sure Professor Clark will explain them, but one of the measures that can be used is to look at functional MRI. And this is very interesting because this is a study where patients with psoriasis were shown essentially disgusting images. And control patients without psoriasis were shown the same images. And functional MRI was used to look at this area of the brain called the insula, which is where we process disgusting thoughts, disgusting images. And what was found is that patients with psoriasis have a very attenuated response to these images. And what that means in practical terms is that patients actually block out the reaction of other patients, or other people rather, to their psoriasis. They don't see it quite the way that patients without psoriasis would see it. And this is almost certainly an adaptation to their condition. They become insular. They actually don't see patients, or they don't see people's responses to their own condition, become withdrawn. And that leads to a little bit of a change in what should be an empathic response, being much less empathic, both with patients and with the people who view them. As I say, we're very lucky to have Alex here, and there are a lot of sorts of therapy that she can use. One of them is cognitive behavioural therapy, changing the mindset, if you like, of the way that patients view themselves and view their surroundings. Certainly a lot of what she does is very useful, because whilst we're using medications, expensive drugs, etc., she's trying a slightly different type of therapy which can yield good results. And PASI is a way of measuring the extent of skin involvement with psoriasis, and 75% basically means it's very severe. The higher the number, the worse the psoriasis. You can see that 64% of patients in one of her small-scale studies, admittedly, achieved a reduction. I think this is actually PASI reduction, and that is shown here also. DLQI is another measure of severity of functional status. PASI is the clinical correlate, in other words, what we see as doctors in terms of skin coverage. DLQI is what patients themselves perceive as their own functional status. And going from there to a better functional status is what Alex often finds with these patients. We also find that patients can be discharged from dermatology. We haven't yet looked in any great detail at psoriatic arthritis, but inevitably some patients will have access, who have both conditions, to this service. And it seems to be a positive contribution to patient care. Patients find it useful. They can often return to work in a much easier fashion without us having to increase their drugs. And of course, the need for reassurance is one of those things that many patients of all conditions need. They need to see their doctor, they need to see a nurse, and there's a decreased need for them to access the service. Now, before I finish, I just want to go on to the last bit of the talk, and then I'm happy to answer questions. We mentioned that psoriasis is associated with a large number of different organs, so the eyes, the joints, the skin, nails, tendons. This is one particular aspect which is very, very underrepresented in people's, patients, as well as GPs and other hospital consultants' knowledge about many inflammatory conditions, and that is cardiovascular disease. This is common, and you don't need me to tell you that. So a lot of patients will have heart disease. 141,000 patients have heart attacks per year, who are men, women, slightly less than that. So there's a large proportion of the population out there that has significant heart disease. You'll all know some of the risk factors for this: smoking, high blood pressure, diabetes, being obese, and high cholesterol. High cholesterol particularly, a lot of you, it's easily measured. Your GPs may have measured it and said it's too high, go on X, Y, and Z drug. So these are so-called modifiable risk factors that we can actually change. What we now understand, however, is that it's not just heart disease, it's not a separate entity. There are a lot of inflammatory conditions that seem to be linked quite strongly to heart disease. So what we understand now is that heart disease and these inflammatory conditions are not separate. Actually, maybe they cause each other. And the question that I would like to ask is, which is chicken and which is egg? You know, do we now think that heart disease, or rather inflammatory conditions like rheumatoid, like psoriasis, cause heart disease? Or actually, could it be the other way around? Are people who are primed to have heart disease, could they actually develop some of these conditions if they are so primed? And we don't know the answer to that yet, but we know there is a strong linkage between these inflammatory conditions and heart disease. This is a diagram which basically just shows you the complexity of what we're talking about on a microscopic level. So basically, the sum total of this diagram is there are a lot of factors that are produced by cells that circulate around, damage the wall of the blood vessel, and cause fatty deposits, and that causes heart disease. And I don't want you to take away anything else apart from that. The link is that inflammation within the joints, or synovitis as it's called, can release some of these mediators that seem to accelerate heart disease. How does psoriasis fit into this picture? Well, we know that psoriasis actually, apart from being a nasty condition, apart from causing all these other problems, actually is associated with increased mortality. You lose about 3 to 5 years of life if you have psoriasis, particularly severe psoriasis, not so much mild psoriasis. So it does kill you a little bit earlier. And the figures I want you to concentrate on are SMR, which is standardized mortality ratio. This, basically, the higher this is, the worse the disease is for killing you. So to put it into perspective, diabetes, heart disease may have an SMR of between 1.5 and 2.5. So this is still pretty elevated. Psoriatic arthritis, likewise, can cause a significant increase in mortality. So this study done in Toronto looked at the mortality of patients with psoriatic arthritis and found it was higher. Why should that be? Why are these patients dying earlier than we might expect? Well, the answer is that most of them have circulation problems. So in other words, heart disease, strokes, heart failure or CCF or congestive cardiac failure. So a lot of them, the patients actually die because they have cardiac disease. And this seems to be why patients with these conditions die a little bit sooner than you might expect. And if we look at the risk factors these patients have, you might argue, well, you've already told me they're a bit big, they're a little bit diabetic, they have high blood pressure. Well, they do. And if you look at certain studies, patients with psoriasis and psoriatic arthritis in this case actually do have a higher body mass index. They are bigger. They do have an increased level of diabetes. And they do have a higher incidence of high blood pressure. So you might argue, well, they've got a higher risk of having these conventional so-called modifiable risk factors. What we also know, however, is that obesity can actually be a direct link. It can actually activate some of the cells which actually cause some of the heart disease in the first place. And so these conventional risk factors undoubtedly are important in the premature heart disease that occurs with psoriasis and psoriatic arthritis, because we know that fatty tissue can activate some of these cells that causes insulin resistance and heart disease. So could that actually explain some of the issues that we have with increased heart disease? Is it, in other words, just a convergence of factors that cause heart disease together with this disease, psoriasis? This is another graph showing basically that diabetes is much more common. This line here, anything above 1 is greater than the control population. And you can see here, particularly in the younger age groups, psoriatic arthritis and psoriasis are associated with a stronger risk of diabetes. So there is undoubtedly a convergence of conventional risk factors, diabetes, high blood pressure, etc., associated with psoriasis. So could that just explain why these patients get high levels of heart disease? So is it just because they've got an excess of normal risk factors, or is it due to the disease? And one of the things that we look at are lipids, are cholesterol studies. And what we find, oddly enough, is whereas you might expect cholesterol to be much higher in patients with psoriasis, and maybe that would explain the heart disease, what we actually find is another paradox. Actually, active psoriatic arthritis is not associated in all cases with high cholesterol. It's actually associated with lower cholesterol. And it's associated, as with rheumatoid arthritis, which is also a strong risk factor for heart disease, with lower cholesterol. What's happening there? You know, I thought higher cholesterol gave you heart disease, therefore you needed statins to cure it all and you'd get better. Well, it's just not the case that inflammatory disease like psoriasis causes high cholesterol. A lot of our patients have very normal cholesterols and end up with heart disease. And this is the so-called lipid paradox. Looking at other studies, we can also see that actually conventional risk factors, if you strip all of those out, and you know, the statistical whiz kids can do this quite easily. This large study, which actually looked at the UK general practice database, despite the fact that the study was actually done by a group in Toronto, and this is 5% of the UK population, so this is a large study. And this looked at psoriasis and the unadjusted data. In other words, patients with psoriasis with whatever other comorbidity like diabetes, hypertension, smokers, high cholesterol or whatever. Severe psoriasis was associated with cardiovascular mortality. But if you then strip out all those risk factors and just look at the disease, again, severe psoriasis, not so much with mild psoriasis, but severe psoriasis significantly increased your risk of cardiovascular disease and death. So there's no doubt that the disease itself is to an extent driving the heart disease. It's not just having an excess of risk factors like diabetes, which are also associated. It's the disease itself that is driving this. And the risk seems to be highest in the younger age group. So in other words, the younger you are with severe psoriasis, the more likely it is you will die younger because of heart disease. Atrial fibrillation, basically just a wobbly heart, a funny heartbeat. Stroke and psoriasis also seem to be linked. So it's not just heart disease. Strokes also seem to be linked to psoriasis. And again, we can strip away the effect of these conventional risk factors like diabetes. And this graph basically shows the red line, which are patients with psoriasis, and the green line, patients with milder psoriasis, and the control patients without psoriasis. So who gets atrial fibrillation, stroke more frequently? Is it the control patients? No, it's not. It's actually patients with severe psoriasis have a far higher incidence of atrial fibrillation, which is another risk factor for stroke. So these patients with severe psoriasis get not only heart disease, they get strokes much more frequently. And this is another facet to psoriasis care. And we can see with strokes, again, not only atrial fibrillation, but strokes themselves at a much higher level than they would be if patients didn't have psoriasis. I think we'll skip over this one, but again, it's the same story, that basically the risk of heart disease, psoriatic arthritis, is elevated. And I think that is probably the take-home message. And this is another issue which I mentioned before. So basically, which came first? You know, could actually heart disease prime an individual to have chronic disease of another kind? And Kimberly Nettleton, one of my BSc students here last year, looked at this and found that patients with psoriasis, if you look at these patients and look at their family history, patients who have psoriasis have first-degree relatives with heart attacks much more frequently than patients who don't have psoriasis. So there's clearly an issue that maybe there's a family history or a genetic history of heart disease and psoriasis which seem to be converging in some individuals, allowing them not only to have higher risk of heart disease, but also psoriasis as well. This is a very interesting study done in mice which tries to link heart disease and psoriasis. And these are a special cohort of mice which are looking at blood vessels here, and these are the control mice without psoriasis, and these are mice with psoriasis. And what you can see here are sections of tissue which look at the blood vessels, and you can see this is a normal blood vessel. This is not at all a problem in the normal mice. In those mice who have psoriasis, however, the blood vessel is congested, it's filled with inflammatory cells. Now, we don't know why, but clearly these mice who have psoriasis are giving rise to an inflammatory process which is causing damage to blood vessel walls. And as we've said, this seems to be the psoriasis that's causing it, not any other modifiable risk factors. This is Kimberly looking at another patient here who is having a check of what's called carotid intermedia thickness. And this is an indirect measure using this ultrasound probe on the carotid artery that allows you to determine whether somebody is at risk of heart disease. And this has been used because the obvious question we want to know is, if we treat patients, will they actually not only get better, but will their risk of heart disease improve? And there is some evidence, although it's far too early for us to say, that actually using some drugs might actually reduce the risk not only of the disease and the damage of the disease, but reduce your risk of heart disease as well. And there's some evidence that using statins might be a good thing to use even in patients who don't have high cholesterol. It may actually reduce your risk of future heart disease. So statins may be a drug that we will be using a lot more of, not in the cholesterol setting, but with a view to actually treating future risk of heart disease in people who don't even have high cholesterol. And this is the sort of trace that Kimberly gets. You can see these are fatty deposits on the carotid artery here. You can see them quite clearly. So the management of, I'm just going to finish in a minute or two. The management of these patients presents another challenge because in a busy clinic, you know these patients are at risk of heart disease. So we rely very much on our GP colleagues also to help out with things like smoking cessation identifying high-risk patients, measuring weight, body mass index, because we can also say that body mass index, if it's reduced, can actually help psoriasis as well. There's some evidence for that. So all of this becomes a challenge in a busy clinical setting, and it's one of the reasons that I'm particularly keen to try and expand our service to incorporate these kind of very essential tools to help patients not only with their clinical condition but their future risk of heart disease. So in summary, before I finish, just 1 or 2 slides after this and that's it. We know that psoriasis is actually a multi-system disease. It's a very debilitating disease which is associated with work disability, which is associated with relationship problems, psychological problems, but also physical disease as well. And for this reason, a group of researchers around the world have set up the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, which I'm very pleased to be a member of. And this is a coming together of rheumatologists, dermatologists and allied professionals. And we've got our own mini grappa here. And as you can see, I think I'm the lucky one actually, 9 lovely ladies and me, but this is our mini version. So Sandy McBride runs a psoriasis clinic, Alex Mazzara is our clinical psychologist, Annie Waite, Philippa Tinsley. All of these people have contributed hugely to what we're trying to do at the Royal Free, which is to try and set up an integrated service for patients with psoriasis and psoriatic arthritis. So they don't have to come and see Sandy on one day and then 3 months later have to see me. Why can't we just do this all in one go? And seems sensible. So we're trying to put forward a business case to that end. Costings, as ever, are the big key to this, but I hope in the near future we will have more information for you on that. And I just want to say a very big thank you for all of you who've sat through the talk.